I'm Dr. Keerat Sibia, consultant pulmonology from SPS Hospitals and Sibia Medical Center, Ludhiana, and I'm so happy to be here with you all today. I thank Dr. Krishna for taking cognizance of the fact that we were all talking about hemopsis and our issues that we were having with interpreting CTPA and talking regarding embolization. And Sir has been kind enough to promptly take up this topic. And I think it's very relevant because the incidence of hemopsis in the winter season is on the high side. I personally have had about 5 to 6 cases of hemopsis in this past 1 month itself. So, without further ado, let me begin to talk about hemopsis. We all know hemopsis is expectoration of blood, which comes from the lower respiratory tract, and the blood can be from the alveoli or from the lower respiratory tract airways. Talking about causes of hemopsis, the most common cause of hemopsis, when we think of in India, we think tuberculosis, but let's go through the other causes as well. Causes being tuberculosis, of course, fungal infections, malignancy, bronchiectasis, chronic bronchitis, pulmonary embolism, CCF or DAH, iatrogenic causes like pulmonary arterial interventions with devices, anticoagulants, and trauma, vasculitis, bronchial artery aneurysms, pseudosequestration, and some congenital disorders like pulmonary artery atresia or stenosis or PABMs. Causes of hemopsis can be primary or secondary. Primary causes are those where the pathology lies in the either in the at the vascular level, which could be chronic systemic vascular hypertrophy or focally damaged vessels, or it could involve the parenchyma with dysplastic lung parenchyma with systemic pulse arterial supply, or arteriovenous malformations and fistulas, or bleeding at the capillary level. Although the bronchial arteries are responsible for most cases of hemopsis, systemic arteries and pulmonary arteries are important potential causes and must be recognized. We could also think of hemopsis and the causes and in terms of the mechanisms which are involved. Say we talk about the primary vascular mechanism, there could be systemic vascular hypertrophy or there could be localized vascular pathology. So when we talk about the systemic vascular hypertrophy, it could be seen in cases malignancy, cystic fibrosis, bronchiectasis, tuberculosis, or NTM infection, or lung damage from any prior infection. Similarly, mycetoma or CHF, ILDs, fibrosing mediastinitis, chronic thromboembolic pulmonary disease, CHF, or proximal interruption of pulmonary artery. Looking at the focally damaged vessels or the local pathology, there could be malignancy, tuberculosis, fungal pneumonia, bacterial pneumonia, septic pulmonary embolism or infarction, then large or medium vessel vasculitis. And then there could be injuries which could be iatrogenic or like biopsy related or ruptured thoracic aortic aneurysm or aortobronchial fistulae, airway stent erosion or radiation. Causes could also be linked to the dysplastic parenchyma, or there could be arteriovenous malformation of fistulae, which could be congenital or which could be related to chest injury or biopsy or chest tube placement. And mechanisms which involve bleeding at the capillary level could be due to vasculitis, which could be small vessel vasculitis. It could be related to medication or illicit drug abuse, or thrombocytopenia or mitral stenosis. Now, the secondary causes, when we think secondary causes, it means processes which are directly destroying the lung parenchyma or processes which are invading the airway. It's important to understand the difference between the primary and secondary causes because this information will help us derive our further plan of management. Looking at the secondary vascular mechanism, it could be parenchymal destruction secondary to malignancy, tuberculosis, or any other infection, or pulmonary embolism or infarction, or it could be airway invasion secondary to malignancy or bronchiolithiasis. So, if it is a single episode of hemopsis, should we be concerned? Should we be alarmed? Or should we just wait and watch? Certainly, we should be alarmed and we should never take even a single episode of hemopsis lightly, because we may think things will be okay and they may not work out that way. Now, without further ado, let me carry on with our two presentations for the day. Our first presentation is by Dr. Nikhil Gupta, and he will be talking to us about CT angio. And this will be followed by our presentation on radio interventions in hemopsis by our guest intervention radiologist, Dr. Sandeep Moudgil. I welcome Dr. Nikhil. to take his talk.
Good evening, everyone. First of all, I would like to thank Dr. Krishna and CCI family for having me here. Uh, we will talk about CT angiography for hemoptysis today. I am Dr. Nikhil Gupta, and I am a consultant in radio diagnosis and imaging at SPS Hospitals, Ludhiana. This study showed the value of multi-detector CT angiography before bronchial artery embolization. It showed the accuracy of CT angiography in identification of culprit arteries was very high, as close to 97.5%. So, in conclusion, it should be performed before bronchial artery embolization in every patient. Uh, what is the importance of CT? CT is a non-invasive tool in management of hemoptysis, and a systemic approach is followed. In first step, we have to identify the parenchymal and airway hemorrhage signs, and in second steps, we have to determine the mechanism of hemoptysis. What are the general principles of CT? Chest, uh, we scan from lung epicenter to posterior costophrenic angle in a supine patient in full inspiration, scan duration of 2.5 seconds, and detector width of less than 1 mm, that is 0.7 or 0.6 mm, and contrast agents are given. Coming to CT pulmonary angiography, it is a specific imaging protocol to optimize diagnostic information. The scanning direction is generally from base to apex due to respiratory motion. However, in newer CT systems, because of high speeds, it does not matter. Breath hold is done to reduce motion artifacts, and increase vascular resistance also promotes pulmonary arterial contrast enhancement. Uh, it can be enhanced by hyperventilation or pre-breathing with oxygen prior to the scan. Quiet breathing can also be done. It should not be problematic. And we should avoid Valsalva maneuver. Contrast injection, concentration, and injection rates. The contrast is given at 1.5 mg per kg. That is around 100 to 125 ml of contrast, which is 350 to 370 milligram iodine per ml. And it is given IV at the rate of 3 to 4 milliliter per second. Automatic bolus triggering software is used with region of interest placed over the main pulmonary artery at 200 HU. It is followed by saline injection known as saline chaser. 30 to 50 ml of saline is given, and it permits the use of less intravenous contrast while maintaining good image qualities. However, it requires a dual power injector. These are the parameters for CT pulmonary angio, where maximum kilovolt peak is around 140, and maximum milliamperes second is 90 to 120. With, as we have seen, the contrast 350 to 370 ml at the rate of 3.5 to 4 milliliter per second. As we increase the rate of injection, we decrease the time delay between the injection time and acquisition of scan. Reformatting is done in planes. So multiplanar reformatting images or 3D reconstructions are done. Also, maximum intensity projection images can be used. Pitfalls are divided into anatomic or technical pitfalls. The anatomical: veins, lymph nodes, pulmonary veins, volume averaging, impacted bronchi, pulmonary arterial catheters, cardiac shunts, and pulmonary arterial sarcoma. Technical factors being respiratory and cardiac motion, improper contrast bolus timing, and noise, image noise or quantum modeling. Incidental emboli, uh, these are important in because in such patients, these are always at high risk for thromboembolism, and this finding may be extremely important and often results in significant changes in patient management. This is a case showing infectious pseudoaneurysm in a cavity. This is another case showing infectious pseudoaneurysm inside this cavity. This is a case showing post-radiation tumor pseudoaneurysm, as seen here. And it is a case of acute pulmonary embolism where the embolism is in the center and contrast is in the periphery. This is a case of acute right ventricular dilatation following acute embolism, pulmonary embolism. This is, in contrast, this is a case of chronic pulmonary embolism, in which the embolus is to the periphery or eccentric, and the contrast is in the center, which can be seen here. So this is a chronic pulmonary embolism. Coming to CT bronchial angiography, it is done in continuation with CT pulmonary angiography with no additional contrast and a time delay of 10 to 15 seconds. However, if this is a standalone scan, then 100 ml of contrast is given at the rate of 2.5 to 3 ml per second with around 30 seconds of delay. How to reduce the risk of ionizing radiation? By increasing the awareness, increase automatic tube current modulation technique, optimization of field view, avoidance of unnecessary imaging, and iterative data reconstruction techniques. The advantages over DSA are we can visualize the wall of the vessel, surrounding changes, parenchymal pathology, intramural hematomas. Also, it has a rapid imaging time, ease of use, less expensive, and it is less invasive. The common arterial sources of hemoptysis are generally bronchial artery, most common. One right, two left are the most common type at D5 or D6 level. Ectopic bronchial artery can also arise from under surface of the arch of aorta, as seen here. The posterior intercostal arteries are also culprit. Then vertebral artery or thyrocervical trunk or internal memory artery or costocervical trunk or lateral thoracic arteries can also be seen, which can cause hemoptysis. Also, inferior phrenic arteries can also cause hemoptysis, which itself may arise from celiac artery. Then this is a case of hemoptysis with normal caliber of bronchial artery, which was embolized and patient became stable later on. This is a case of enlarged bronchial arteries, as seen here. This is confirmed by DSA, and it is showing blush. These are right-sided enlarged arteries. These are left-sided enlarged arteries with blush. This is a case of anomalous bronchial artery from undersurface of arch of aorta as a source of hemoptysis. This is a case of common bronchial artery dilatation, as seen here in the 3D reformatted images. This is a case of hemoptysis from the intercostobronchial trunk, and here it is seen here, and this is showing blush in DSA. On DSA, sorry. Then these are systemic collaterals from the intrapleural arteries, which also presented with hemoptysis. This is a case of hemoptysis with complex blood supply from bronchial, internal memory, and lateral thoracic arteries, as confirmed on these DSA images. Then this is a case of mycetoma with dual supply from intercostobronchial arteries and the internal memory arteries. This is a case of intrabronchial course of hypertrophied right bronchial artery. This is a case of aplasia of the pulmonary artery, right pulmonary artery, and there was systemic collaterals supplying the lung. This patient came with hemoptysis. These are known as MAPCAS, MAPCAS, major arteriopulmonary vessels, collaterals. This is a case of bronchial artery aneurysm seen here on DSA images also. This is a case of unstable aortic aneurysm presented with hemoptysis seen as ground glassing. This is an aortobronchial fistula. This is a case of bronchial artery to pulmonary vein malformation as seen here and here. This is a case of endobronchial carcinoid tumor which was removed surgically and proven on histopathology. This is a case of bronchiolith causing hemoptysis. In this case, a patient presented with hemoptysis after anticoagulant medication. No artery was dilated, and patient was managed conservatively with, and the medication was stopped. This is a case of small vessel vasculitis with hemoptysis showing crazy paving appearance. This is a case of fungal ball with surrounding hemoptysis, as seen here. This is a case of sarcoma mets with this metastatic focus showing hemoptysis around it. This is a case of interlobar acquired pulmonary sequestration due to this foreign body, which was spinal fusion instrument. And this is the supply artery from the aorta, seen confirmed on these images. Then coming to indirect CT venography, following CT a study for diagnosis of pulmonary embolism, we can assess a patient for venous thromboembolism in legs and pelvis. And the scan is obtained 3 minutes after the initial contrast injection without additional contrast. However, it is not widely practiced, and instead, ultrasound Doppler of the lower limbs is done. In conclusion, CT is an important non-invasive tool in evaluation of hemoptysis. Multiphase CT is advantageous to decrease patient exposure, and it evaluates both pulmonary and bronchial circulations with systemic collaterals. Also, it can look for venous thromboembolism. Then we have to understand the potential mechanisms of hemoptysis and their imaging features, and also the pitfalls and limitations of CT bronchial and pulmonary arteries for accurate diagnosis. Thank you very much. Now I hand over to Dr. Sandeep Moudgil for further talk. Thank you very much.
Good evening, everyone. I thank the organizing committee to give me this opportunity to share my views. So I'll be talking about the role of interventional radiology in hemoptysis. So this is the prerequisite for, as in any other case which we take in interventional radiology, that is we consider whether the patient needs anesthesia, which type of anesthesia is required. Consent is mandatory. The procedure is invasive and anything may go wrong. And the patient needs to be resuscitated before any ambulation is undertaken. Hardware check is the primary responsibility of the operator to make sure the procedure is completed successfully. Beforehand knowledge of the comorbidities of the patient give us the clue about the possible causes as well as the problems that one may encounter during the anesthesia or during the embolization. This is usually emergency setting call which we receive. So in the life of an IR, the first question is, do I really need to wake up at this hour? These are usually midnight calls that patient is bleeding and come for intervention. So for this, there is a simple checklist. I just asked my calling clinician, that emergency clinician, that how bad is the patient bleeding? So that simply means the indications and contraindications. According to CIRSE, any hemoptysis which is causing significant airway compromise or respiratory distress, or if there are more than or equal to 3 episodes of greater than equal to 300 ml of blood in a week, or any hemoptysis which is chronic or slowly increasing, needs to be addressed by intervention procedures. Absolute contraindication is if we have a branch which is supplying the diseased lung parenchyma or which is bleeding and which is also supplying the vital organs, maybe heart, spine, or the brain. So that is absolute contraindication. But with the advent of the newer hardware and the techniques, it's always possible to negotiate beyond the origin of those vessels and embolize specifically embolize the bleeding arteries. The relative contraindication is congenital pulmonary artery stenosis, wherein the bronchial artery is the main supplier of the lung parenchyma. So once the indication contraindication is done, then next point for any intervention is where the blood is coming from. Is it what is the major cause of the bleed? In Indian setup, is it tuberculosis or the causes related with the tuberculosis, be it bronchiectasis, especially more respiratory aneurysms? Other causes can be other infections like pneumonia, chronic pneumonia, necrotizing, or abscess. It can be malignancy, primary or metastatic malignancies can be cause of cryptogenic bleed. It can be because of chronic lung diseases like interstitial fibrosis, COPD, or bronchiectasis, pneumoconiosis, especially in the area where I'm living in, where the stonework is very common. Patients usually come with the silicosis or pneumoconiosis with superadded tuberculosis and patient bleeding with from the respiratory aneurysms. Patient may be on anticoagulants and bleeding because of that. So once it's done, the next thing is to analyze from where the artery is coming. And this is a point where the intervention general radiology, diagnostic radiology has a major role has to play. And for deciding the major causes of the bleed, we need the scans to lateralize the things and see the status of the arteries and the pulmonary bronchial artery, pulmonary arteries, and the lung parenchyma. So whether it is artery, so arteries can be the bronchial arteries, which may be orthoptic or ectopic. It can be the visceral arteries, the branches of the subclavian, maybe vertebral, the cervical, costocervical, lateral mammary, or lateral thoracic. It can be because bleeders from the posterior intercostals, or in rare occasions, especially when the disease is confined to the lower lobes of the lung, the bleeder can be from the inferior phrenic artery, which is arising from the abdomen, or in some cases from the celiac trunk. The bronchial arteries has a very typical pattern. In 40% of the cases, it is usually intercostal bronchial trunk on the right side and two left bronchial arteries. Intercostal bronchial trunk further divides into right bronchial artery and the intercostal arteries. In type 2, this can be one ICVT and one left bronchial artery. In type 2, there are two on each side, either side. And in type 4, it's just a mirror image of the first one. That is, we have two right bronchial arteries and left bronchial arteries. The importance of these is once you know these patterns, it's easier to look for the origin of these vessels, cannulate and embolize them successfully. So once it's done, in respiratory aneurysms or pseudoaneurysms, these are the veins which are the culprit and need to be tackled. So parenchyma can be the cause of the bleed. So once we know what's the cause and from where the bleed is coming, so we need to plug the leak. How can we do that? So this is not the thing. The most important point before we go to plug anything is to evaluate the radiology again. That is, review the radiology. So in my cases, I always prefer to review my own radiology until unless Dr. Nikhil is reading my scans for me. So I need to see where the pathology is, which part of the lung is involved, what is the status of the aorta, abdominal and thoracic, and what are the arteries, what is the pattern of the arteries, what is the status of the non-bronchial systemic vessels. So once that is done, I make my route. Which route will I take? Whether it will be arterial or it will be the venous route or it is the percutaneous route. What are the tools which will the embolizing agent I will be using, and how I will proceed with my case. So usual embolizing agent, most of the time it is the particulate materials. These particles are usually 300 to 900 micron in the size, and most commonly that I use is the PVA particle ranging from 350 to 500 microns. So these are basically irregular zigzag, and they clog the bleeding vessels well. The disadvantage is that they may clog the microcatheter or the itself. Liquid embolic agents, that is NVCA glue, is a very wonderful embolizing agent, but it needs skill. So it has to be used with caution. And in the expert hands, this is the most successful agent where the chances of recurrence and control of the hemoptysis is excellent. Gel form is rarely used. It's only a supplementary agent. Microcoils and vascular plugs are used in special situations. Access depends upon the cause. It can be artery or the vein. It can be right femoral, left femoral, or in some cases it can be radial. So diagnostic catheter is taken into the aorta. vessel is cannulated, selective angiograms are done, and the findings which are suggestive of the hypertrophic bronchial arteries or culprit bronchial arteries like tortuous, enlarged bronchial arteries, is neovascularity, parenchymal blush, maybe pseudoaneurysms or AV fistulous communications are the findings which may be seen on angiograms. One abnormal artery is cannulated, then it is super selective cannulation is done, then angiogram is done, and the particular area is embolized using different various embolizing materials as we discussed. And finally, the closure of the access site is done. Each point, these points is important because any lapse of these steps will ultimately cause the failure or incomplete embolization or failure of the procedure, or may lead to the complications. Aortograms are maybe done every time. This is one of the cases where I embolized the non-bronchial arteries, and just to ensure that I didn't miss any ectopic origin of the bronchial arteries, I had a flush aortogram. This was recently done on 14th of February this year. Here, what the diagnostic catheter look like. This is selective cannulation and right intercostal bronchial trunk, these are the intercostal arteries. There is some tortuosity. The main culprit vessel is the right bronchial artery, which is showing there is early filling of the bone, tortuous, they are hypertrophied, there is abnormal parenchymal blush. So plan was to take catheter till this and microcatheter to this point from here to embolize, because any vessel which is arising on going to the medial side from this point can be a supplier of the spinal artery, and inadvertent embolization of that artery may cause paraparesis. So that has to be brought in mind. So this is what was done in this case. Super selective cannulation of the right bronchial artery was done, and this is post-embolization run, which shows complete obliteration of the abnormal flush. It's the same case, left-sided bronchial artery. This is just to show inverted image to show you the pathology of the lung, the abnormal tortuous vessel, this is abnormal parenchymal blush in the same, and here is the video of the embolization. This was embolized using PVA particles of the size 350 to 500 micrograms, and patient had some tortuous vessels from the thoracocervical trunk, and these were tortuous. Abnormal blush was seen in the expected right apical lesion of the lung. Additionally, this is important to note that these also supply the soft tissue of the neck, the trachea, and the esophagus. So all these vessels are to these organs. So the plan was to not to embolize these things. For this, I used the larger particles. These were the size of 700 to 900 in this case. So just as to clog these vessels. So this is how it was done. So these are the embolizing material that was injected. So once it's all done, what I just want to sleep comfortably, and I want my patient to be comfortable and hemodynamically stable. For this, I have to plan my procedures very meticulously, expect, anticipate, and avoid the complications, because complications, though there are less, but when they can be dreadful, especially when we have a spinal infarction because of inadvertent embolization of the anterior spinal artery, or embolizing material may go from the vertebral arteries or from the arch of aorta into the anterior posterior circulation, and maybe the cause of stroke, and which is not uncommon. I had one of in my institutes. So other are common things like post-embolization syndrome, which usually subside with the analgesics. Patient may have chest pain or dysphagia because of embolization of the few branches of the chest, trachea or the esophagus. There can be embolization of the vasa vasorum of the aorta, and maybe cause of the complications. This is one of the examples where we have another example where intercostal bronchial trunk is giving rise to the intercostal arteries and the right bronchial artery, and there was a branch arising on the medial aspect, and which was supplying to the spinal cord. This was missed, and which led to the paraparesis. This is one of the letters written to the editor. When the pulmonary pseudoaneurysms are bleeder, the access is through the venous. So we reach to the venous pulmonary artery and across the heart. This is super selective cannulation, angiogram showing the pseudoaneurysm, and this was glue embolized in this case. Many times when the cavities are peripheral, they can be approached percutaneously, transthoracic percutaneously under CT guidance, and the glue can be embolized through the needle. So this is a cheap, quick, and effective method of treating respiratory aneurysms. Many at times when the etiology, like in this case, there are multiple pseudoaneurysms In the case which had vasculitis, one may use vascular plugs, but obviously they are costly and affordability is an issue in our patients. So conclude, any patient with hemoptysis, so the first thing to see whether it is non-life-threatening or life-threatening. In life-threatening, obviously, resuscitation and after basic investigation, CT angiography is done. If it shows abnormal bronchial arteries, then we proceed for the bronchial artery ambulation. And if it shows there is abnormality of the pulmonary artery, then pulmonary artery ambulation may be endovascular percutaneous is done. And if there is a localized disease, then surgery is the option. Bronchial artery may act as a bridging procedure to buy time between this by the time surgery is arranged and if the measurement is conservative. So these are the guidelines from the CIRSE as well. Those were the guidelines from the Institute of Chest. And this is MDCT. If it shows parenchymatous origin, bronchial attenuation can be straightway taken and clinically monitored. If it is okay, everything stops there. And if it is endobronchial origin, then bronchoscopy is done, clinical monitoring, or whether bronchial attenuation is or clinical monitoring is taken according case to case basis. So this concludes my talk. Thank you for patient listening. Thanks a lot.
Thank you, Dr. Sandeep Moudgil, for such an enlightening talk. And I'm so happy to note that you have taken great details into consideration and shared details with us, which we generally don't come across only. We don't bother that what hard work the interventional radiologist is putting into the procedure, but we are just generally very thankful that you've come and done the procedure. But thank you for such a wonderful talk. And thank you, Dr. Nikhil, for such an interesting talk on pulmonary and CT pulmonary and bronchial angio. Let me start today's webinar by welcoming our panelists. Let me begin by welcoming Dr. Nasser Yusuf, who is the pioneer in VAT surgery and mediastinoscopy. Sir is consultant CTVS surgeon from Sunrise Hospital, Kochi. And welcome, Dr. Nasser. Next, I would like to welcome Dr. Ramesh Bharate, sir. Sir is professor and head at Government Medical College, Latur. And heartiest welcome, Dr. Ramesh. I would now like to welcome our guest interventional radiologist, Dr. Sandeep Moudgil. He's also my senior from college, and it is such a pleasure to welcome Dr. Sandeep Moudgil. Sir, welcome.
Thank you, Dr. Keerat. Thanks a lot.
Thank you, sir. Next, I would like to welcome Dr. Tridib Chatterji, who is consultant pulmonologist, senior consultant pulmonologist from Raheja, Shushruta and Kikabai Hospital, Mumbai. Welcome, Dr. Tridib.
Yeah, my video is not coming on. You please continue. Audio, I think you just...
okay, you are with us. Please.
Yeah, I can hear you, but only my camera is not working. Please continue.
Next, I would like to welcome our interventional pulmonologist on board. We're all doing intervention, but a special mention for Dr. Viswesvaran because we all know how much he loves intervention. And Dr. Viswesvaran is from Yashoda, Hyderabad. Welcome, Dr. Viswesvaran.
Thank you, Dr. Keerat.
And last but not the least, I would like to welcome Dr. Nikhil Gupta, consultant radiology at SPS Hospitals, Ludhiana. Welcome, Dr. Nikhil.
Thank you so much, Dr. Keerat.
So without further ado, I would like to begin today's session and we'll start building on the Q&A. And I would like to direct the first question to Dr. Tridib, sir. Dr. Tridib always asks questions whenever a webinar is going on. So I want to start this time with
1 minute. Can you just talk? They have certainly host has stopped my video. Can you just talk to them?
We can hear you, so please continue to answer while they sort that out.
Okay.
So please do not consider this as a revenge, but more of an special interest I develop because I always find Dr. Tridib's questions are there in the CCI webinar. So Dr. Tridib, let's start by talking about hemoptysis, causes of hemoptysis. Could you please elaborate causes of hemoptysis and causes of pseudohemoptysis?
Okay. So first, before we start, as usual, I would like to thank, and as you had mentioned that we had just had a small case discussion. I think it was your case, and as usual, your team, Dr. Krishna, yourself, Dr. Vijay, and all, within 2 weeks, I put it up, and it's absolutely great. And I think no other organization in India can do this way. So first, that is my first thanks.
Thank
This
you,
is
sir.
absolutely marvelous. Now, I think causes, I think most of it, many things you have described also when your preliminary talk. So I can divide it in various ways, the classification. So I just use one simple way, like you first talks of infections. So infections, as you know, tuberculosis is, and its equally bronchiectasis because of any infection. Then any pneumonia, as you were saying, any suppurative pneumonia or the necrotizing pneumonias, then lung abscesses can cause this thing. Then even sometimes the atypical infection like an hydrated cyst, that can also, it's not uncommon, and patient might present with hemoptysis, and then when you do a scan or something, you find there's an hydrated cyst. So, and of course, the last but not the least is the aspergilloma. That is one of the causes of major cause of hemoptysis and massive hemoptysis. Now, after that, you have the neoplastic causes, the primary bronchogenic carcinomas, the metastasis, then the bronchial adenomas, like something like a carcinoid, which can bleed a lot. So when you see it, and you should always avoid doing a biopsy because that is the one which bleeds a lot. Then what we cause, the causes caused by the doctor, the iatrogenic causes. So bronchoscopy, or enthusiastic transbronchial biopsy, or a little bit, or even something the rough endotracheal intubation. Swan gans by these cardiologists can cause hemoptysis, and then they are sent to us. Then the traumas you mentioned, blend traumas, penetrating traumas, they are the causes. Then the vascular causes. So that causes, in the vascular cause, you can have primary vascular causes like pulmonary embolism, especially if there's a pulmonary infarct, where there's a right-sided pain and then hemoptysis. Or vasculitis can happen in good pastures, SLE, or granulomatous angiitis. The drug-induced, which is like, as Dr. Nikhil showed, one patient on antiplatelet or anticoagulations. I remember about 2-3 years ago, we had a lot of dengue problems in Bombay, and patient used to come on a ventilator with hemorrhagic fever because the platelets were down to 1,000, 2,000. So those can be also considered. You have to keep that in mind in the right setting. Another cause of the is AV malformation. I remember one case distinctly of mine, a lady with periodic little hemoptysis presented with anemia. And then we further worked up and found that multiple AV malformations. Then I went back in the history and found that similar patients were in the family, and the diagnosis came as Osler-Weber-Rendu syndrome. So, of course, we could not get the angios in the previous patients, but this patient, we had done the coiling as Dr. Moudgil got. In some patients, there the coiling was done. So, AV malformations is one cause. And, of course, chronic bronchitis, I forgot, that is also one of the important causes. And the miscellaneous causes, that is catamenial hemoptysis along with menstruation. Then pneumoconiosis, which doctor, again, he mentioned the silicosis people coming there, or lamb, or I think one case of what I think Dr. Nikhil showed looked like a lamb with multiple cysts when they were hemoptysis. And one last but not the least, which we are probably going to discuss here, is the idiopathic or cryptogenic, which is in some cases almost 20 to 30% of the times that you do everything and you still don't know where you are. So these are roughly the causes of hemoptysis. But in this whole confusion, if you list out the most commonest causes, at least in India, it probably would be TB, mycetoma, infection, pneumonia or lung abscess, bronchitis, acute, especially COPD with bronchitis, and maybe an aspergilloma, your pulmonary embolism. These would be the commonest causes which we would see. And here I would like to say that all of them need not cause massive hemoptysis. They could be mild hemoptysis. And massive hemoptysis, there is no actual consensus definition. So it can be 100 ml to 200 ml. It is what is important is it is compromising on the patient's respiration. His oxygen levels are down, his BP is down, patient requires intubation. That is massive. It could be 100 ml or it could be anything. And very interestingly, I found out there is one term which is given for massive hemoptysis, which I never knew, that is hemoptysis, which is used to designation for massive hemoptysis. This I learned today first time. So after doing this, then there is, you mentioned about pseudo-hemoptysis. So hemoptysis means the blood is coming from below the vocal cords, from the lower respiratory system in the tracheobronchial tree or in the vessels. But what is coming above that is pseudo-hemoptysis. So actually pseudo-hemoptysis means, actual definition is when the sputum doesn't contain RBCs. And that is commonly because of an infection by something called as Serratia marasina, which is a nosocomial infection, usually seen. Patient come with blood and you send it for examination, and you will find that there is no RBCs seen. That this is the common, patiently many times commonly are using nebulizers or inhaled medicines, which can cause the pseudohemoptysis. Or other thing is in children, because upper respiratory system, and always remember to see the dentist, the gums. These are important causes. And the last but not least is to differentiate it from hematemesis, because especially in children, sometimes they swallow the blood, so you cannot sometimes make out. Although theoretically it is supposed to be darker, there is history of retching, but sometimes you have to actually examine that, see whether there are food particles, it's an acidic pH. So that is how you differentiate from hematemesis. So these are all forms of pseudo
Yes, sir. Very well elaborated. Here I would just like to add, I think you've covered almost everything in detail. Only one thing that comes to my mind is Serratia marcescens can also cause...
I think I told that.
Okay, so excellent.
I told that.
So we have, we covered all the bases here. So next, I would like to ask Dr. Ramesh a question that is, sir just mentioned, Dr. Tridib mentioned that there can be mild or there can be severe hemoptysis. And traditionally, we've been talking about these terms. So Dr. Ramesh, what are the features of life-threatening hemoptysis? I think you need to unmute. Yeah, please.
Hello, can you repeat the question?
Yes, we can hear you, sir. Please carry on.
So, regarding life-threatening hemoptysis. Hello?
Yes, sir. Please carry on.
Yeah. Can you repeat the question?
Yes, sir. What are the features of life-threatening hemoptysis?
Okay. Question, madam. Again, already Chatterji sir has very well explained the causes of hemoptysis. Life-threatening hemoptysis means at least more than 600 to 1000 ml blood loss within 24 to 48 hours. And patient may have respiratory failure, ongoing hemodynamic instability like hypotensions. Then patient may require oxygen supplementations. Patient may have these other features like sweating, palpitations, and patient may require hospitalization of massive hemoptysis.
So, sir, basically, wherever there is hemodynamic compromise, we will say it is certainly life-threatening hemoptysis. And here's what I feel. I feel that traditionally we've been saying, oh, little amount of hemoptysis, this is mild hemoptysis. But seriously, if you talk from your experience, and I'm sure a lot of people here would agree, I think we can never say this is mild hemoptysis, because you never know which next episode could be a life-threatening hemoptysis, turns to a massive hemoptysis. And to say that it is massive or it is life-threatening now, because now the airways is compromised, I think we need to move beyond that and we need to be more proactive now. And we as pulmonologists really hold that, I think the onus lies on us to educate the practitioners around us that even a single episode of hemoptysis has to be taken very seriously. It's an important sign, and you can never say that, oh, this is mild hemoptysis, so let's wait. And I'm sure, like when we look at our books, while we were reading about mild hemoptysis. What do? Line of management, you wait, you give it some time, you let the medicine work. But I have had patient sitting, patient fine, and patient on room air talking. Single episode, we were awaiting approvals for the CT pulmonary angio. It's an expensive test, and then you need approvals also from the insurance. This was a patient from railways awaiting insurance. And the next bout, after 12 hours or 12 odd hours, was so severe, he had to be intubated, and it only was a downhill course from there. So sometimes just to say, oh, it's mild, I think that's the importance of stressing on life-threatening hemoptysis. I'm sure you would agree, sir. So moving on, my next question is for Dr. Viswesvaran. Dr. Viswesvaran is here with us. Okay, I think he was. All right. So the next question is, how do you evaluate a patient with hemoptysis? And I'll get the ball rolling. So we have a patient who comes with hemoptysis, and I think this is a sphere which has really evolved over time. We have had traditionally we would say, okay, let's do the HB. Let's see how much is this the fall in HB. Let's see if there's any coagulopathy. Let's see if there's any thrombocytopenia. So, Dr. Ramesh, how would you like to take it further? Let me start with you. You have a patient with hemoptysis. How would you like to start the evaluation?
Okay. First of all, very important thing is we have to examine the case whether patient is having uh, finger clubbing, which indicates patient is having bronchial carcinoma or bronchiectasis. And other signs of malignancies like whether patient is having hepatomegaly, lymphadenopathy, and whether patient is having unilateral leg swelling to rule out pulmonary infarction, and systemic diseases like whether patient is having purpura, rash over the skin, or any lymphadenopathy or splenomegaly is there. And on examinations, in respiratory patient will have features of bronchial carcinoma. Their patient will have fractures bilateral. Where patient is having bronchiectasis, and there will be a sign of consolidation and pleurisy in pneumonia or pulmonary infarctions. And if patient is having cardiac cause, the patient may have signs of heart failure, and sometimes there will be a pulmonary hypertension and mitral stenosis also. So,
So we start right. So we start with the clinic physical examination, and we try to locate the cause of hemoptysis. And so when we have a patient who comes to the emergency, say patient had an episode of hemoptysis, first of all, beginning with the physical examination to determine the cause, then to determine the severity, we determine whether the patient is hemodynamically stable or not, whether there is any desaturation, any airway compromise, and that's how the things get moving quickly. But this is if we stress on the fact that we take that every patient of hemoptysis is a patient with at risk of massive bleeding. So we try to rule out any coagulopathy. We get the blood test done because we also need to see what the hematocrit is like. We need to see if the HB is less than 8. We need to get blood grouping done. We need to be ready to arrange blood as well if required. And then if any liver function, like you just even stressed on hepatobiliary examination, patient may be having deranged LFTs and maybe at increased risk of bleeding as such also. So we evaluate with that, and then we move on to investigations. Other than the labs, we move on to the radiology. The quickest thing we can get is a chest X-ray in the emergency.
Like chest X-ray, CT scan, sputum examinations, and full blood count is very important.
Is very right. So we move on to the chest X-ray, and then we would only because chest X-ray is the quickest possible radiological examination that is available in the ER. But then my question to you, sir, this question is to Dr. Tridib. Sir, would you prefer to do HRCT or CECT or a CTPA directly in a patient who is having hemoptysis?
No, so if a patient has got hemoptysis, I think if the patient is stable enough, I think first I would do an X-ray. I don't think we should discount the X-ray. But if it is a massive hemoptysis, then first you have to stabilize the patient. And I mean, we may not get time to do anything. But if it is a mild hemoptysis, patient has come with repeated, probably the best thing first you would do an X-ray, especially if there are physical findings of RALs on one side or some bronchial breath sounds or something which is make you suspecting a local parenchymal lesion. So probably I'll do an X-ray, but the X-ray chances are not very. I mean, the chances are only I think 30-40%. So then probably I do a scan. If I do a scan, probably I will do a contrast scan. I will not do a plain scan. I would directly go a contrast scan as Dr. Nikhil showed how you can differentiate, but much better than just doing a plain scan, which you may not, where you get the parenchyma as well as you will get it. But CTPA, I don't think I will do as the first choice. I mean, right from the beginning. This is what I would kind of do it. But of course, patient has to be stable to do all this.
All right. So this. I would like to have the radiologist's opinion on it. And I would like to come to Dr. Nikhil. Dr. Nikhil, what do you think we should do? We have a X-ray. It is showing a cavity. Now the patient has had some bleeding. Do you think the next investigation we should go in for is CECT chest or CT pulmonary angio?
Actually, it is a multimodality, multiphasic CT. Exactly. First, we take a plain scan, and then we give a contrast, take a CTPA view. Then we wait for 15 seconds, take a CT bronchial angio, and also we can evaluate the veins later on after 3 minutes in the same scan. So it is better to do this because within 5 minutes you will get the complete picture of the bronchial arteries, pulmonary arteries, or any other source. Plus, you will get a baseline HRCT to compare with.
So this is my practice. Whenever I have a patient of hemoptysis, I actually get a CT pulmonary angio, bronchial angio done as soon as possible. And here's where I would like to bring in the interventional radiologist, Dr. Sandeep Moudgil. The thing is with bronchial artery bleedings, these are rarely seen in real time. And we have to rely on the caliber of the vessels to see whether they are at risk for bleeding. So that is my reason for choosing a CT angio as the first line after a basic chest X-ray. And what is your take on this, Dr. Sandeep?
Dr. Keerat, whenever I receive a call for, usually these are the acute and massive hemoptysis when they call us. So my line of action is very clear. I just want to have a negative CT angiogram or a CTBA, bronchial angiogram, so that I can sleep.
So actually, trust me, this is what we want as well, because we just want to make sure we're not missing out anything.
That's a very valid point. As Dr. Nikhil said, NCCT, that plain chest, plain CT is must, because that gives me the baseline. What exactly is picking up the contrast, when it is picking up the contrast. I shall have shown it in my talk. Second is, as he said, is first thing is whenever you are giving the contrast, you are putting the patient in the CT gantry. It's a matter of 30 or 40 seconds more. So do a pulmonary angio, CTPA, followed by a bronchial. And as he said, we prefer to have a delayed scan. Because what happens is, as you are making the point, that you may not see the bronchial artery bleeding. Forget about CT angiography. We don't see it on real time on bronchial dynamic angiography, that catheter angiography. We rarely see it. And once we see it, that means we are in a trouble. That is the time when we have to do things very quickly. This happened with me, one of the cases. So the point is, the thing is the 4 scans. One is the must one is non-contrast, CTPA, CTBA, and a delayed scan if you don't find anything or if you're suspecting that some contrast will increase or decrease. So you can either visually analyze, so where the contrast is pulling up, or you can have some subtraction softwares, which is available nowadays.
So Sandeep, Dr. Sandeep, so you don't do a contrast scan there. You directly go for a plain scan, so automatically will come in when you're doing a CTPA. It will obviously come in.
Yeah, that has to be mentioned on.
Okay. But you won't do a plain CT like what you do for a lymph node or something. You would not do that.
Why we want to give additional contrast over and over again?
I just wanted to know their opinion. That's a very good point which I have learned. So directly go in for mentioning a plain scan and then do a CTPA.
Whatever you need. So either you will have cause or you will have a baseline scan.
Yeah, so if the patient has come with hemoptysis, then your main idea is to find out the type source of hemoptysis. So their contrast scan is not really, ECT is not more important. You have to do a plain scan and then do the CTPA and CTBA. That is what I would think.
Yes, Dr. Nikhil.
Nikhil, could you just, please.
The CCT is actually the venous phase. So we are taking arterial phase much before then venous phase. So we can take a venous phase, additional venous phase, actually. That is a CECT.
Achha, okay.
Gives additional information like mediastinum and other structures. But mild contrast uptake can be seen in bronchial phase also.
Okay. So it can come, both can come kind of together if you just...
PCT will be helpful in malignant lesions because all the malignancies they will enhance. So that will give the idea whether it is consolidation or it is a malignancy point. So that will be one thing which is really important to know about.
Okay.
And as far as these bronchial arteries is concerned, the rule is anything which can be cannulated should be embolized. Especially because when patient is at stake, you cannot take a call because you have a variety of embolizing agents. You don't want to kill the artery, just put a gel form there. It will be gone with 7 to 10 days. Artery will be intact and patient will be fine. Because what happens is in real case scenario, the arteries which are bleeding, they are actually undergoing the vasospasm. And we may not be able to pick that up. Secondly, whenever it's massive hemoptysis, you already have given the blood products. The RBC is given, and RBC, when the blood transfusion is there, the chances of picking up a bleeding artery further reduces. These are the studies there. It's proven facts. Okay. So that is this is what happened. The case on 14th of February, the patient was he had 3 times he had the massive hemoptysis. He was embolized twice. And this was the 3rd time he presented. He presented to my institute. Initially, when he was embolized by one of other doctors in my institute, he had stroke. So he immediately recognized me. You are the one in that same team. Okay, fine. Yeah, I told him. And it was the bucket full of the blood. I'll share the images on the WhatsApp group. It was literally a bucket full of the blood. I was just passing across the emergency and I saw, oh shit, I have to stop here. Then I told him, okay, fine, stabilize the things. The entire emergency team was all around the guy. The 2 pure red cell RBCs were given, the full, whatever you call it. The complete blood was given and I waited for 3 hours. And then they handed over the case to me. The CT pulmonary angiography, CTPA and CTBA, it just showed one artery which was prominent and one artery that was coming from the thyrocervical trunk that I showed in the case. Now, what should I do? So I performed a bronchial iotogram out there. I just made out my plan. Okay, these are the things. And I just hooked into the left bronchial artery. It was like the right also. So I just went into there. It was so fine and thin that my catheter was not sticking in. I have to change 5 catheters. The 5 shapes. Nikhil will understand this. I changed SIM1, SIM2, C1, C2. Then ultimately it was the RDC that worked for me. And it was around 4 hours haul for me. I started at 9:30 and descrubbed at 12:30 or 1. So in those cases, we just embolize it. And my plan for this case is I'll call him after 14 days where everything is settled. Now I'll do a complete angiogram. And then I'll try to find out if some bronchial artery is coming from right side or left side, some aberrant vessel is there. So this is from interventionist point of view.
So this is obviously very, very interesting. And
very interesting. Very interesting.
This detail comes in. I would like to bring in our thoracic surgeon, Dr. Nasser. Sir, what is your take? What are the urgent indications to consult a thoracic surgeon in a case of hemoptysis?
Thank you for allowing me to be part of this very august group. I find Sandeep very passionate Nikhil very cool and very clear in his comments. Dr. Tridib, we're probably the same age, always very enthusiastic. Bharat, fantastic background you have, being greeted by the Chief Minister, I guess. And Kirat, you were very good in your introduction. Well, surgeons have a different perspective, right? Now, I do not know where to start, where to go. We heard a lot of things. Maybe I can start with where Sandeep left off in that case, where he was facing this problem. What we would do, and it takes me back about 10, 20 years back when bronchial arterial embolization wasn't very popular in the country then, early 2000. It was there, but not very popular. We had a similar situation, a patient coming, young guy, 28, massive hemoptysis, whole casualty was full of blood. It was around 11 in the night. And we're very clear, no other information we had. He had some old chest x-rays, which showed a lesion on the right side, right upper lobe, classical. We just put central lines and took him straight to theater. There was evidence and was probably, we didn't have time for a CT scan, nothing. Took him straight to theater, did a right upper lobectomy. And what you do is go in straight, clamp the bronchus, immediately open and clamp the bronchus, the bleeding, you save the left side. You protect the opposite side to prevent aspiration. And once that is done, then things set. Once you clamp the bronchus, you're under control. You are the master of the scene. And then you can take time and do a right upper lobectomy. That was the approach of surgeons. So coming back, so I took you off on that line. Maybe if you have a localized lesion on your HRCT, which you have done, or your CT, which you have done, you just have to probably go and tackle that area and the problem should be sorted out. Now, what we have seen over the years, I think about 50 years back is where bronchial arterial embolization was first done for various things, uterine bleeds or gastric bleeds, and then it developed onto the thorax. Is to us, what comes in mostly, I work in a very kind of a tertiary center, referred from patients from different hospitals, is invariably they would have had a bronchial arterial embolization. Those are the patients who come to us. I'm not trying to decry or criticize because it's a very open topic. You need a kind of a panel discussion on this. So what we see are the failures of bronchial arterial embolization. But failure rates, you will know better. Various studies have, including the one in seminars in interventional radiology, there are papers which say from 50 to 75 to 94% success rates. But what happens? You have a follow-up rate. After 2 years, it drops to 77, 85%. And what happens? Now, you have to have, all of you have to think on a different perspective. We have been focusing, I have to stop here to thank Dr. Krishna for organizing the CCI webinars. Three, fantastic job. I've often refused him, but he was so particular that I come on. So this, when we see, is what we see, like, there was a confusion about hemoptysis, less than 200, 600, above 600. That's a classical teaching of minor and, moderate, massive, life-threatening, well-described threat to life, basically hypotension or fear of aspiration. So coming back to your point of where exactly would we step in, is it would be great that we could have a bronchial arterial. It helps us, a bronchial arteriogram, which tells us specifically the area. Now, more important, then we know this is the area where it is bled. This is the lesion, because sometimes you have multiple lesions, right? You have cavities in the right side, you have cavities in the left side, you have hemoptysis, you don't know where it's coming from. So as a practice, we always do a bronchoscopy to ensure and lateralize which area, which lung it's coming from, or which lobe, if possible. Difficult to say which lobe because it is usually soiled. So then what we need to think is it is not hemoptysis we are treating. Please remember that hemoptysis is just a symptom. So he has other symptoms. Maybe he might have cough, he might have fevers, he could have recurrent chest infections. So it has to be seen as a holistic picture of which hemoptysis is part of it. So we need, if we treat hemoptysis alone, you're treating the symptom or single symptom, but not the cause. So please don't lose sight of the cause. Maybe a cavity. Will cavity vanish with bronchial arterial embolization? Will an aspergilloma vanish? Will bronchiectasis vanish? Hydatitis vanish? So please think in a wholesome approach. Of course, we need to deal with hemoptysis. When you do surgery, again for surgery, not all cases of surgery, not all cases of hemoptysis we can do surgery, but those cases where it's indicated, where it's localized, lateralized, patient is fit, then we can deal with all this. Take out the cavity, hydrated system, or bronchiectasis. What are the pathology? Pulmonary infarct. That's one area which is not common, but pulmonary infarct is another area. Pulmonary artery itself can be a cause of bleed, although the percentage may be around 5 to 10%. Trauma itself can cause hemoptysis. So these areas we can treat the cause and have a permanent kind of solution. So bronchial arterial embolization, first line of treatment, perfect. I agree with that. But if there's a chance, as Sandeep said, huge bronchial arteries all around, others would open up when this closes up in time, may open up. So have a permanent kind of solution, a concrete approach, treat the patient, basically.
I would like to add in this, sir. Case I was discussing. The last when he was embolized, I saw that lesion was in the upper area. It was in the left upper lobe. I specifically told them, go to CTV surgeon. Even I asked him to make an OPD slip and get it removed. It will bleed again. It was such a thick rind. And it's recruiting. The vessels are gone mad. They will keep on recruiting. If it is not first intercostal, then second intercostal. If not that intercostal, then lateral thoracic. Somewhere it will come, it will keep. Until unless you remove that area. And he didn't follow the advice just to come again after 1 year. Exactly after 1 year, he came to us again.
So, Dr. Nasir, I would just like to ask you on this, because these mycotomas are a fairly reasonable common cause. So suppose you have done an embolization, Dr. Sandeep has done an embolization and he has stopped. So would I send it to you for a surgery? Because as you said, the mycetoma, it will remain. It's not going to go away. So if it has one moderate to severe, I think then we should go for a definitive kind of. Is that a kind of right inference? Would I think that's the right thinking?
Out of respect, I call you Dr. Tridib Chatterji. Over a drink, I might call you Tridib. But Dr. Chatterji, you put the question, if you answered you answered it too. You're spot on.
So if there's an indication for surgery,
in my institute,
or not, you will still operate a destroyed lung. If you want to, look at a hydrated and you are going to operate, you're going to do that anyway. So hemoptysis just makes it more evident that, so easier to decide on getting operated early and convince the patient also, I believe, in some manner. Now I would like to come to Dr. Viswesvaran. Dr. Viswesvaran, how would you say, could you elaborate on the role of bronchoscopy in hemoptysis?
So we had a very interesting discussion from both the interventional radiologist and the thoracic surgeon. So regarding the bronchoscopic role in the hemoptysis, it will always come secondary. It is not going to be your first line. So when I mean secondary, let's say the patient is coming to you with a massive hemoptysis. It is not that you jump and do a bronchoscopy. The first and the foremost thing is you need to stabilize this patient. So the stabilization we mean by protecting the airway. That can be done simply just with your ET tube. Let's say that the patient is having from the X-ray, from the CT scan, which side of the lung most probably the patient is bleeding from. All that you need to do is you need to intubate this patient and selectively isolate. Let's say that the bleeding is occurring from the right side. Then you just if you are not skillful enough to immediately do any bronchoscopy, all that you need to do is you need to put the ET tube directly into the left main bronchus and occlude it so that at least you will be ventilating the normal lung and protecting the normal lung from getting flooded with the hemoptysis from the other lung. The next thing is always put the patient on the dependent position. Let's say that the right side is bleeding, put the patient on a right lateral position so that the bleed does not enter into the left normal lung, and do an active suctioning. And the most important thing is you need to stabilize the hemodynamics. So make sure there are 2 lines that is put. And once it is done, if you have an immediate access to a bronchial artery embolization, then that would be the first line of management which we will do. Generally, we look into the feeders, we shift the patient to the cath lab, we look into the feeders, and then do the embolization. And after that comes the role of the bronchoscopy, where you go in with the bronchoscope, clean up do the bronchial toileting so that these clots do not cause the collapse of the lung. And then if the patient is having active hemoptysis from a particular site, then what you can do with the bronchoscopy is you do something called as a spigot occlusion, spigots with a glue occlusion. So, but having said that, it has been like only in 1 or 2 cases where we actually required a bronchoscopic intervention for a massive hemoptysis. So the bronchoscopic utility will come, one, in bronchoscopic guided intubation, whether you want to put it into the left main bronchus or into the right main bronchus, or for the bronchial toileting of removing the blood clots. Or very rarely, in one case, it so happened that the patient came to us with an invasive pulmonary aspergillosis and the patient was actively hemopsing. And we intubated the patient. We wanted to shift the patient to the cath lab, but the cath lab was busy. There was a cardiac procedure going on. So we needed time to stabilize this patient. So what we did is we took a silicone spigots. We went with the bronchoscopy. We went to the right upper lobe from where the cavity was there and it was bleeding. We placed the spigots. We placed the glue so that now the bleeding is confined only to the upper lobe. So we bought time. Then we took up this patient for bronchial artery embolization. We embolized the patient. And then we were able to save the patient. But apart from that, except for bronchoscopic guided intubation or for bronchial toileting or for getting a bowel sample to prove the etiology of the infective cause, bronchoscopy would not be the primary line of management when you are dealing with a case of a massive hemoptysis. Your routine intubation skills, call for help from the interventional radiology colleagues. And once the interventional radiology is able to identify the feeder and occlude it, well and good. But if he's not able to identify the feeder because of diffuse multiple feeders, then the best thing what you can do is call your CTVS surgeon and go in for an immediate lobectomy or a therapeutic, whatever is needed for the patient. Sometimes they may even end up doing a pneumonectomy for such patients, especially when you're dealing with a case of a post-TB destroyed lung where there is a diffuse bleeder across the lobes. So for all the young interventional pulmonologists here, don't jump in doing a bronchoscopy immediately you see a hemoptysis patient. You first, all that we need to understand is stabilize the airway. That is the most important thing, and call for help. Make sure there are 2 lines. Make sure you give a call for arrangement of blood products. Call your interventional radiology colleagues and have your CTVS surgeon on the backup. So these are the things that are actually required and not a upfront bronchoscopy.
Excellent, Dr. Viswesvaran. Thank you so much. And so we've covered the thoracic surgery part, we've covered the radio intervention part, we've covered the bronchoscopic interventions. Now I would like to ask Dr. Ramesh that, sir, what should be the stress in terms of medical management of hemoptysis? Where should we focus?
Management, probably our aim should be when to admit the patient. First of all, whether patient is stable or unstable. And our aim is to stabilize the bleeding process in patients who is having risk of massive hemoptysis and to correct the disorders coagulations like clotting factors or whether patient is having low platelet count and other. And to stabilize the gas exchange. First of all, we should localize the site of bleeding and then adequate pulmonary, whether patient's pulmonary functions are properly active or not. Then again, it is very important whether patient is having underlying carcinoma or distant metastasis or patient is having cardiovascular disorders like mitral stenosis.
So right.
Yeah, and if patient
Here
is
I would
having,
like, yeah.
if patient
Please carry on.
If patient is having
So I really like that Dr. Nasser mentioned that we should not lose sight of the entire of the patient in terms of just thinking of stopping hemoptysis. We should look at the primary cause of hemoptysis. Like you
Yeah.
just said, that we locate the cause. And I think the medical management that traditionally we talked about was let the patient rest. We do not give bronchodilators ever in patients who's having active hemoptysis, but we do give cuff suppressants. Sometimes they even say you should give some level of sedation, but then that's also very tricky because you don't want the patient to be so sedated or drowsy that the patient aspirates and asphyxiates. So this, I think we have been very limited in our medical management. In like it has been limited to stabilizing the patient, providing blood products, and just keeping the patient hemodynamically stable, and then also giving specific treatment. Say if the patient has a fungal lesion, then we choose the appropriate antifungals or start the patient on ATT, and so on, right?
Yeah.
Next, I want to ask Dr. Nikhil Gupta. Dr. Nikhil, is it possible for a patient to have hemoptysis and a normal CTPA?
Obviously, it can happen. In most of the cases, the CTPA will be normal. It will be the CT bronchial angio that will be abnormal, where we can find tortuous bronchial arteries. And if CTBA is also normal, then it is a case of cryptogenic uh, hemoptysis.
So if, for example, I get a call, if I get we rely heavily on the radiologist. So if there's a late night CT pulmonary angio, bronchial angio, which is done and it is reported grossly normal, how much should I take that as it at its face value and sleep well at night? Oh, it's normal. Should I let the interventional radiologist sleep?
No, you should not.
If CTPA, the
Wait,
FDA is
Dr.
there
Sandeep,
saying it's
please.
That's why I have mentioned it in one of my slides. I go and review my radiology myself.
normal.
Until Nikhil is reviewing my scans, I don't believe anyone. But
So I
and that is
have to commend you for that.
because sometimes the bleeds are sentinel, and next time when they will bleed, you don't know how much they will bleed. You don't want you cannot let a patient sink in his own blood. So if that is at see it yourself.
So let me be more particular in what I'm trying to point out. Is there anything you would think that the pulmonologist should be familiar with when it comes to the protocols for CT angio imaging?
I think in this, the teamwork is what that matters. In my hospital, interventional radiologist, diagnostic radiology, pulmonologist, and CTVS, you work hand in hand. So whenever a patient comes of hemoptysis, they will definitely send to us, to IR, patient will come. And anyone who's coming to us will go to CTVS. So this is sort of, this is nothing written out there, but this is what comes.
Dr. Nikhil, would you like to give your opinion on this? Say a normal reported CT angio and patient is actively bleeding, having active hemoptysis. What should I do? This is a desperate condition.
A normal sized bronchial artery can also be abnormal. As sir told that it can undergo after bleeding, it can constrict. So that can also happen. And generally, we review the CT ourselves. That's true. I also always review my CT. I don't believe anyone's report, like Vice. And the main thing while reporting CT bronchial arteries that we give the exact place of origin of the artery and its exact diameter, what we can see on CT, so that it is easy for the interventional radiologist to hook that artery at that vertebral level.
Thank you very much. Coming to Dr. Tridib, sir. Sir, as you mentioned in the very beginning itself, that tuberculosis is the most common cause of hemoptysis in India. Yeah. So what we should be careful with when we are dealing with hemoptysis in a patient with active tuberculosis?
So first is, as you said, if the tuberculosis cavity or something is the first is the primary to treat the main cause. That is the first thing, stabilize the patient. But if there is a massive hemoptysis in spite of the treatment, then I think probably you would send the patient for an embolization. bronchial artery embolization. But remember, there is also in tuberculosis, there is sometimes this Rasmussen aneurysm, which is actually at the pulmonary circulation dilated, just the vessels which are along the cavity, which they erode inside the cavity and form a sort of a pseudo aneurysm. So because they can also be caused. So in that case, you should be aware of that as a cause of hemoptysis. Tuberculosis it can also happen in the healing phase, where a calcified lymph node can kind of erode into the bronchus, which can cause it. Then the mycetoma is another cause. So it is not too different from what has been up to treat the cause, stabilize, and if after stabilization, if the cavity is bleeding and there is a sufficient amount of AKT gone, and the patient has had a massive amount of hemoptysis, then probably I would at some stage send the patient to Dr. Nasser for removing that lobe, because if patient is on AKT for 3 or 6 months and there is a cavity and you have kind of localized the bleeding from there, just doing an embolization is not going to be enough. But yes, patient should have probably have taken a good period of 3 to 6 months, 3 months of AKT, as I think the surgeons would require 3 or 4 months, and should preferably be negative. A BAL should be negative. Then they could have a better chance of getting rid of that bleeding site. Otherwise, it's the main TB treatment which is the main thing here. I think I covered everything. Anybody wants to add something?
Thank you very much. So you just mentioned pulmonary circulation. Dr. Batra from Delhi sends her or his greetings. And Dr. Batra says, what is the management for hemoptysis due to pulmonary circulation? Is it just conservative, as it is less life-threatening due to low pressure system? So I would like Dr. Nasser's take on this.
Very valid question. Very valid question. The pulmonary artery can have its branches at times going directly into the lobe. Well, this is only about 5 to 10% of patients, and especially the role of hemoptysis comes in, or hemoptysis occurs when if there's a pulmonary embolism, and that leads to a pulmonary infarct. So that once it's infarcted, there's no ventilation happening, there's no perfusion happening, minimal ventilation, I should say. So in that situation, that can continue to cause, although it is low pressure, bleeding. So for that cause, the best would be to take out that particular segment of the lung, or very rarely a lobe. Along with this, I need to just say, important thing is to stop the bleeding. So when surgery comes in, we talk of VATS, we talk of open surgeries. We should not lose sight of the ultimate aim. Ultimate aim is to stop the bleeding, save the patient. If facilities or the skills are available for VATS, go ahead. But that should not stop you from saving a life. And in an emergency, VATS is a long, time-consuming procedure. It is an open procedure. Open procedure is the procedure for an emergency, while VATS, if it is very controlled system. Secondly, in fact, thirdly, coming to Dr. Chatterji's statement, absolutely sensible, practical, logical statement. If the patient is stabilized, give a minimum of 3 months. If not, if the patient continues to bleed, bronchial arterial embolization fails, no matter what, AFP positive, we go in, save the life, then we'll deal with the tuberculosis later. Because why this logic has come in is, one is a patient bleeding to death. Many patients have empyema. We do not know that patient has tuberculosis. After surgery, doing a decortication segmentectomy, then the report comes as AFP positive. So kicking out, hitting all the guidelines through the window. So where you have to say 3 months dena hai, uske baad hi kar sakta hai. No, so that led us to think, save the life, we'll deal with it later. As Dr. Chatterji said, minimum of post-surgery, minimum of 6 months in an AFP susceptible patient, in MDR-TB, 18 months or so till it becomes negative, and XDR-TB, maybe even 24 months. You are the experts. You guys know better. So
Excellent elaboration, sir. And I would like to reiterate the same question, but ask it in a different sense to Dr. Sandeep. So, Dr. Sandeep, I'm going to exactly read out what Dr. Batra said. Dr. Batra says, what is the management for hemoptysis due to pulmonary circulation? Is it just conservative as it is less threatening due to low pressure system? How I would like you to answer this with respect to PAVMs.
Okay, pulmonary artery AVMs.
Yes.
AVMs. Fine. So if we can see a AVM or AVF, the treatment is very straightforward. You always have plugs and coils, and there is no parenchyma at stake. So just go, put a coil, plug it, and come back. So that is one thing which is treatable. The issue arises is when the source is ambiguous. You are suspecting pulmonary artery as a source, but you don't see any aneurysm, Rasmussen aneurysm. In that case, if the lesion is focal, disease is localized to one lobe or one particular area, I think surgery is the best option. Because whatever you may do, it will again bleed. Whatever, if this is on the right side, left, the next time it will be also superior aspect. Somewhere the process is going on. We are not actually stopping the process. Rasmussen aneurysm, once developed on one side, will develop on some other side. The necrosis is a continuous process. It's going on. The drugs are not reaching into the cavity. Body is not able to put forth an inflammatory reaction and defend itself. So it will go on. So the only way in this is to take the disease part out. Yes, if it is diffuse thing, then we have to go and empirical things are only left in those cases. And another one is the bronchial artery. The next question reads about the bronchial artery. Success rate of bronchial artery. Yes.
I'll come to that. But this question I want to take further. And I'm going to talk about pulmonary circulation. I want Dr. Nikhil to come in here and tell me, again, Dr. Batra's question. Management for hemoptysis due to pulmonary circulation, conservative. Should it be conservative because it is less life-threatening due to low pressure system? But Dr. Nikhil, here I would like you to talk about MAPCAs.
MAPCAs are major aortopulmonary arterial collateral vessels. So these arise in the embryological circulation when the pulmonary artery is stenosed or atretic. So it is very common in TOF patients or patients with pulmonary atresia.
The point to drive home is that pulmonary circulation, thinking it is low pressure, thinking of it as harmless, may not always be the right approach. What is how would you opine on this? Open to the panel to opine on this.
Actually, MAPCAs can bleed. So,
as I was telling you my case, that not massive bleeding, but enough that the patient's hemoglobin had dropped to 6 or something like that. And then she came out the history kit. Every month she gets hemoptysis. So in that workup, it showed multiple AV malformations. And then we went to the history and found out similar thing. And that's how we diagnosed Osler-Weber. So it's that there was small hemoptysis, but enough to cause anemia. So you cannot just go on just a value of the pulmonary pressures. It's, as Nasir was saying, it's the whole patient. If the patient is symptomatic enough to cause a hemoglobin drop to 8 and every 3 months there is hemoptysis, maybe only 20 ml, but that's enough to work up the case and not just conservative. Conservative is maybe one episode and not more on that. I think that is what I would think.
I agree. And here I would like to just, share with everybody that we are very happy to announce that we have 1294 logins. This is what we had at 9 p.m. It may have gone beyond that, but this is thanks to the constant hard work by Dr. Krishna, Dr. Atri, Dr. Chenam Chetty, Dr. Shivani Swami, that they keep up the good work. And I'm so glad that the audience finds value in CCI webinars. Thank you, everybody, for joining in. So next, Dr. Sandeep, let's take up the next question by Dr. Batra. Dr. Batra asks, what is the success rate of bronchial artery embolization? One. Number two, reasons for its failure. Third, management if it fails. And next, I think the question goes on to Dr. Nasser. How many BAE can be attempted to go for surgical option? I'm sure Dr. Nasser would say that why do a BAE? Let's go directly for surgical option when you suspect failure. But let's start with the Dr. Sandeep to answer this.
The answer is in the question itself. How many BAE can be attempted? If you have to attempt BAE second time, so why are you attempting it? You buy time, there is a local disease, give it to the surgeon. Let it operate it. So that means we need to understand this. Bronchial artery embolization is a stopgap arrangement. We are just buying time. Okay, we may treat few cases which don't require it, but that skill, the acumen of the treating IR, whatever it is, the best will be and anyway somewhere 70 to 80%. But still we will have a large number of cases, and especially in Indian scenario, the TB is 80% of the causes of hemoptysis. You cannot take TB out. It will keep on recruiting the vessel, as I said earlier. And another thing is success rate. Yes, I have answered that question. Reason for failure is not identifying the culprit vessel is the main cause. And it's not possible at times. I told you my case scenario. I'm yet to review that case, to do an extensive survey of that and give it to the surgeon again. So this is all I have to say on this.
Your take on this, Dr. Nasser?
Sandeep, excellent, very balanced, excellent conclusion to your talk on interventions. In fact, I have nothing more to add. He's a very sensible guy. I hope he was in my team, so we could work out better. But agreed with Dr. Tridib Chatterji mentioned going for surgery or you mentioned going for surgery straight. But the problem there lies in, it's all out there in the internet, Google. Patients are all educated, at least most of them when they come to us. If a bronchial arterial embolization has not been attempted or been advised or done, we are defensive. Times have changed, Sandeep. If we upright say going for surgery, people are reluctant to accept. It's just like there's very obvious stage 1 cancer. People still would say, why don't you do a PET scan?
You are very right. The guy came to me today. He wanted his varicose veins to be ablated by. I'm sorry, I'm going off the topic. He wanted me to do the laser ablation. I evaluated the entire case. Actually, I did a Doppler myself for 43 minutes, exactly 43 minutes. And I told you don't need it. There are perforators which are gone, and I can just do a sclerotherapy of that. And I had to convince him. He was giving the facts on Google. He was Google educated. The only thing is, I need to know my limitations. That is very important. I have a team who can take care of the rest of the things. I cannot do all the things. I cannot resuscitate someone. I want them to shift the patient to my table and then a surgeon to take care of the things where I fail. This is how the ultimate motto of all we people is to give to the patient. That's it.
Absolutely.
To discharge him happily. One thing.
Maybe
I think it's very important. Please, sir, please.
Maybe in a center, patient arrives where bronchial artery embolization is not available, or the operators, again, Sandeep is being very humble. When he said failure of bronchial arterial embolization, a lot depends upon the operator. Because he may not say that, because he's one, he cannot, talk about it. But we as pulmonologists, thoracic surgeons, we see different results. A guy failing in one center, they ask for a second time, they go in, and that for times 3 to 4 years, they don't bleed. So that's one aspect I feel, Sandeep, I know you're very prudent. You will not like to come into that.
Actually, sir, when I use glue, I know where to use glue. I know how to handle the glue and which consideration I need to handle. And the thing which is going to come again, I'll use glue. As the case which I'm discussing, the index case, I'll use glue in thoracocervical trunk, but now I know which hardware I need. That catheter costs around 70,000-80,000, and he was not able to cough that money out. He was not able to pay that. He was not carrying that money. So what I did is I took old hardware, just do something and just manage that part. But sometimes you success, sometimes you fail. It's all luck, I think.
I'll just come in for one more last time. I don't think there'll be any more questions. But these are 2 points I wish to make, is not to impress upon you, but sometimes the radiologist will know is a lymph node itself can cause an obstruction which can lead to a bleed.
Okay.
Right. So this is a definite points, not very common, but definitely documented. And what we do there is strangely is just take out the lymph node, but usually it's a diseased lymph node, maybe an associated pathology.
Yes, sir. Made this, as I mentioned about it, the calcified lymph node that may erode.
Right.
Made this point, and that was a very good learning point for me. I wasn't aware. I must confess it. I never thought it that way. For me, it's just artery or a vein or parenchyma. That's it.
No, this
Yeah,
I have
that's
actually seen. Actually, I have seen
right,
one.
absolutely.
Of course, the patient settled with normal anti-tuberculosis medicine and did not further get. But when I scoped that patient, I could see that lymph, the caseation and a little bit of that thing, blood coming out from the subcarinal node. So it is known. This is known.
It is known, but not very commonly known.
It's not
You're a
common.
very nice man.
I have seen only one case up till now. But
surgeons, we see maybe a little more. As another point is that there is a surgery known, see a patient, there could be terrible adhesions, Dr. Chatterji, all of you, and it's difficult to reach the hilum. So this is just for information. So what we do is an exclusion process wherein we divide the bronchus, tie off the bronchial artery. That's it. I mean, the pulmonary artery. And when we divide the bronchus, the bronchial arteries are taken care of. And we leave the lung as such there, when sometimes it's impossible because of adhesions to release it. So it's...
Chairperson, I would like to share one more case. It was basically, may I? I think I'm not taking too much of time. So it was around...
No, certainly, sir. You can let Dr. Nasser finish what he was speaking, and then we would love to hear your case.
No, precisely this. So even in a patient, which is say the radiologists say you might feel that it's impossible to operate. Even surgeons say, just all you need to do is go in. It's difficult. Don't bother to take the lung out. Clamp, divide the bronchus, divide the pulmonary artery. That's fine, because then the pulmonary vein pressures don't increase. There's no artery coming into the lung and draining to the left atrium. So that is all that is required. But you're stopping the hemoptysis. You're saving a life. And over to you, Dr. Sandeep.
Dr. Sandeep.
Actually, I used the surgeon's technique in one case. It was 67 years old male, and he was disabled. He was not able to see. Actually, and that he was not able to see, actually, it was blessing for me. Later on, I'll tell him the story. So in the midnight, around 3 a.m. or 4 a.m., he was taken. I saw all the thing. It was a big cavity, right lower lobe, Rasmussen was there. And I was not able to reach. I prefer percutaneous if it is possible, if it is peripheral. It was deep and it was very near to the diaphragm. So the only route was to go through the pulmonary artery. So now Nikhil will understand it was the right femoral vein, then through the heart, from heart to the main pulmonary, right pulmonary, and the inferior division. My catheter was not staying. It's too big. Catheters are very small. 5 French, 6 French catheter. So I took a large bore. Nikhil, I took 088 Neuron Max. I was having ox. So I used it and supported it and went into the vessel. And that was the time. I took around 2.5 to 3 hours. I told my anesthetist to repeat the heparin. Otherwise, the catheter would have clotted. And I told 1,000 heparin, and that lady gave 10,000. I was in the vessel. The moment I take the chute, the clot was dislodged and the guy started bleeding profusely. But he was blind. He could not see the blood. And I told Baba, Yarchi was his name, Baba thukte raho. And he kept on spitting. I shouted at my technician, give me glue. How much percentage? I forget about the percentage, give me the glue. I took the glue. It was, I think, 2 ml glue I took. With 10 ml, 130, 30, I think 0.5 ml of lipidol. Lipidol is the one that make us see where the glue is going. It was around 70-80% of glue. It's very thick glue. And where I was, I just occluded the entire vessel. My subordinate asked me, sir, what are you doing? I'm behaving like a surgeon. I'm knocking off the entire lobe. I don't want to bleed this guy to bleed. I knocked it off. I filled the entire cavity with the glue, and everything settled. And you won't believe, I went to my duty room and I kissed the floor and thank God. It was terrible experience just because of this heparin and all. But yes, that helps. Sometimes when you have nothing, the same thing I did. So what surgeon will do, he'll take the lobe out. This is what I did. I took the vessel out, entire vessel, chop it off. That's what I did that day. It was terrible experience.
Oh, but it is quite the learning experience for all of us. I
Yes.
understand it would be terrible for you. I mean, it sounds so scary.
Resident was so scary, sir will eat me up. Okay, boss, I want this patient breathing. Take care of him. I don't want anything.
I think as pulmonologist, we are limited. I'm learning a lot from you and Nikhil. Of course, our time, my time, ambulation was hardly there. As to only have surgeons operating. Now ambulations come, but it's still so fascinating to learn so many things from you.
I agree with the statement of Dr. Chatterji sir, because I think 20 or 30 years back, only conservative management was existing.
Or at the most surgery, that's it.
Yeah.
But even now surgery, but as Nasir said, that's a very valid point. You must never forget the surgeon. That point is very nice, which you made, Dr. Sandeep. A patient comes, pulmonologist, IR, the CBTCs, everybody is involved in the team. That is the right way. That's the correct and right way. I think that message should be gone out on this platform. That is the right thing.
That is why in today's webinar, we have the radiology people on board and the surgeon on board, because it has to be team. And so I would like to take the questions from the audience quickly again. So this is a question from Dr. Sujata Sharda from Latur, Maharashtra, asking about role of silates or pause injection. Anyone would like to take that?
As such, in conservative management, role of the silate or this
tranexamic acid, or even silate, yes.
They are only used as a conservative management, not as a main treatment. But if patient is having massive life-threatening hemoptysis, the main aim is to protect the non-bleeding lung and vital maintain adequate gas exchange. Along with that, we have to give the supportive medications like vasopressors and fluid resuscitation, correct clotting factors like we can add vitamin K, then inotropes can be added if patient is having hypotension. And sometimes we can give nebulized adrenaline nebulization also. And along with that, oral or IV tranexamic acid can be given. So as such, there is no role of giving this ethamsilate or it's just like giving placebo.
Only, Keerat, I want to just add here that suppose you are doing a bronchoscopy and a biopsy is done, and sometimes you can put in cold saline. There is some things where it can be useful at that time. And here I would like to caution all the people: if there is a cavity, please do not do a transbronchial biopsy from that, because that is a sure shot that patient is going to bleed and going to land up with Dr. Sandeep and maybe even land up with Dr. Nasir. So do a BAL, don't do a biopsy, because that cavity is likely to bleed because of any aneurysm or whatever will be there. Do a BAL, you get your diagnosis of TB. You don't have to do a biopsy to prove it. This is my take here.
If patient is hemodynamically stable and patient is actively bleeding, in such situation we can do bronchoscopy and we can search the whether patient is we can search the proper site of bleeding, so that we can instill local hemostatic agents like ethamsilate or Other
Even glue has been. Dr. Bhattacharya has done quite a few cases.
Yes.
But then there is chance, as you said, it's not 100%.
Yes.
And definitely not for a severe or moderate hemoptysis. There's no question. You don't waste time. As Dr. Viswesvaran said, you directly stabilize, go for embolization or whatever.
Yes.
So I think we have a lot of clarity on hemoptysis for today. Dr. Jayaraman sends his compliments to the wonderful panelists, and he especially compliments the surgeon, says that surgery plays a major role in the management of massive hemoptysis. And I would like to thank all the wonderful panelists. I think we're very wise with early action. I think the take-home message has to be certainly early action in terms of early CT angio, locating the lesion, deciding the cause, and early decision on embolization or surgery where appropriate. And I think this makes all the difference in the world. So concluding remarks from quick one-line concluding remark from everybody, all the panelists. I would like to start with Dr. Nikhil.
Multi-phase CT, that's it. Multi-phase CT is the key.
All right. Dr. Tridib.
I just like to emphasize on the multidisciplinary approach to any patient, where you yourself as a pulmonologist, Dr. Nikhil, and maybe an intervention radiologist, and if required, a cardiovascular. Everybody should be on. And the first thing is to first stabilize the patient and then go ahead.
Dr. Ramesh.
Hemoptysis is a life-threatening situation where we need radiologist along with pulmonologist and cardiothoracic surgeon. So when all these are working combinedly, then definitely we can save the life of patients.
Dr. Sandeep.
Teamwork, ma'am. It's teamwork.
Dr. Nasser. Beyond teamwork, I want to hear from you.
Excellent moderation, and you put in a lot of effort in studying the subject. I could see that from the questions you asked, Dr. Keerat, and you kept smiling right through, managed your forces very well.
Thank you.
Wonderful, and I should thank Dr. Vijay Chennamchetty as well as Shivani for the inputs. It was a pleasure being here. Basically, one should remember, as you said, even mild hemoptysis should not be ignored. That is a warning sign. That's nature or God warning the patient and warning the treating doctor to move into action. Procrastination is the thief of time. So basically, with everything, you move in the proper methodical way. Clinician, investigation, CT, conservative management not working, the interventional radiologist coming in, and then again not working. Don't lose hope. The surgeon is there, and along with him is God. Thank you very much for your fantastic moderation and lovely smiles. It was great, isn't it, Dr. Tridib?
I absolutely concur. Right from forming the questions, maybe all of them got, but Keerat, the way you presented the questions and you done the thing today, it's absolutely fantastic. And of course, you always smile. Whenever I see you on screen or when I meet you, you're always smiling. So that's great.
And finally, the two of us aren't we feeling much younger with this young crowd, isn't it? So,
absolutely. I'm feeling bored. Must have a drink today tonight, I think.
Thank you, everyone. Thank you.
Thank you.
It was truly wonderful having you all here with us today. Good night.
Great. Good night.
Thank
Good
you.
night.
Good night.
Good night.